Thank you so much for coming today on Student Process. This is the Harvard Brain Science Initiative, or HBI 101 series. And today we're really excited to have Dr. Theresa Williamson here with us. She is a neurosurgeon at MGH, as well as a neurosurgical ethics researcher. So she cares for people with all different types of spinal disorders, as well as spinal cord and brain trauma. Her clinical expertise involves tailoring treatments that are individualized and minimally invasive. And she has research expertise in neurosurgical decision-making, communication between patients and doctors, and a variety of different healthcare disparities. She combines bioethics theory with empirical data science in order to tackle these kinds of really complex problems in decision-making in neurosurgery. Dr. Williamson comes to us here from Duke University, where she did her residency and fellowship training. She did an MD in undergrad at Yale, where she was also a varsity soccer player. And amongst many distinctions, in 2017, she was named the Resident Clinician of the Year. She received a leadership award in 2020. And I can say I've come to know her in the past few months or year or so as her role in a new Dana Foundation funded center. So they fund centers in neuroscience and society. And there's one at Harvard on Neurotech Justice, the Center for Neurotech Justice. So it's a pleasure getting to know you in that, and thank you for coming to this. And housekeeping note, if you have signed up for the lunch, you can come to the front here, and we're going to walk to, at the end of the talk, to Goldenson 229. And if you were on the waiting list, or if you want to come and did not get a spot, you can still come up and we can see if we have enough spots.
Thanks, Theresa. Thank you. I think the most important part of that was that I'm a soccer player, and I was saying earlier, I have my FIFA World Cup ticket selection window is now, and I'm still in the waiting room. So if you see an announcement come up, I may have to leave. As far as I mentioned, I'm a neurosurgeon. One update that I haven't given you yet is that I actually am moving my clinical portion of my practice down to Brown. So it was, one of those Ivy League colors that I hadn't experimented with yet. So I missed the one in the middle between Yale and Harvard. And so I will be there for directing their minimally invasive spine program, as well as their endoscopic spine program. And then directing their Center for Innovative Neurorecovery and Repair. And then I will keep an appointment here at Harvard and at Mass General Brigham, thanks to the Neurosurgery department, and continue my role as the director of the Neurotech Justice Accelerator that you mentioned, the Dana Foundation. So I will have lots of jobs. I actually somehow have managed to fill in several. These are some of my disclosures. Nothing's relevant to what I'll be talking about today. My most important job is with these guys. So this is my daughter, who's 4. Her name's Skylar. And then my son is 8 months old. He can't talk yet, so he doesn't get a video. So I'll just
What is it going to be about?
It's gonna be about boats.
This is her
Boats?
helping me prepare
Yes.
talks. It's going to be about boats.
No, it's nothing about surgery.
Some about surgery and some about boats.
Anything
And some
about,
about robots.
and so,
Some about surgery, some about boats, some about robots. So that's my outline of the talk. I'll talk to you guys a little bit about boats,
Okay.
robots, and I'll try to squeeze in that process some surgical ethics and decision making, why it matters in neurosurgery. And I really want to talk to you guys because I understand there's a lot of neuroscientists here, future potentially clinicians, neurosurgeons. But I think, I hopefully will tease you with some ideas, and maybe somebody will take me up on some studies to make patient outcomes better with neurotechnology. So you heard already where I'm from, grew up in the Philly area, and then kind of traveled all around the East Coast. I like to start a little bit with my story because I think it's really important that we bring ourselves to the work that we do. And sometimes in neuroscience that can feel pretty far away because you're like, okay, what do I have in common with an oligodendrocyte or something? But I think the reality is who we are really informs a lot of how we take care of people and why we think things are important. And so when I grew up with my uncle, and I knew him in a way that he was just having been released from a very long lifetime, basically, of imprisonment, and at that time, hospitals for the criminally insane, because he had had a, for lack of better words, mental breakdown when he was around 20 years old. At that time, he was brilliant valedictorian in his class, being drafted by the Phillies. I'm from the Philly area, and committed a brutal murder after not having the appropriate mental health treatment that his family was seeking, and my family was seeking, for schizophrenia. And throughout his lifetime, the way that I knew him was, much later, and I got to interact with him and understand a little bit about the justice system and how it relates to neuroscience and how deeply embedded those two things are. And I also learned a little bit about surgical consent. Unfortunately, we heard about him having a knee replacement after the replacement had been done and had been infected. And that's when they called my dad, who's his legal power of attorney, which was not the appropriate steps, even though he was a ward of the state at the time. Unfortunately, that infected knee implant led to a full leg amputation. And so you can imagine for when we talk about, African-American stories, and my family's an African-American family, we talk about distrust of the medical system. And one of the things that I always like to, think about is why don't people trust us, and have we earned that trust? And so this next picture is one of my dad. My dad was helping babysit my daughter at the time when I went away to talk at a conference. And when I came back, he said, "I can't really move my arm, otherwise I'd help you with your bag." Like, what do you mean you can't move your arm? And he actually had no strength in his hand whatsoever. And he had severe cervical spinal cord compression. And it had been like that for several days. And there was no way he was going to a hospital, even though his daughter is literally a spine surgeon, to get this taken care of, because of the experiences that he's had and that his family had really colored his experience. And so fortunately for him, he has a daughter who's a neurosurgeon who, pushed him to get surgery, and then found him a surgeon to do the surgery that weekend. And he's 85 years old. This is his golf swing after the surgery. So still functioning and doing great. But unfortunately, we see a lot of people lose function and not want to access technologies for a whole host of reasons. That's one from my family, but I'm sure you can think about one from yours or your community, or the people around you, regardless of where you're from. And so that's really been my kind of life work, is to combine this idea of clinical innovation with research. And then also, actually, how do we get it to patients? So once we've done the work and we've developed the technology, how do we then go about helping people to match that right technology with them, helping them to take care of that technology in a way that it continues to show them benefit? And then at lunch, we can talk about the work I do on the side, taking care of ourselves in that process, because it's actually really exhausting to put your heart and your story into the patients that you work with on a daily basis. I was looking recently at my data at MGH after about 5 years, and I did 700 surgeries. So you can imagine how many different times you would have this type of conversation. And if you're going that in depth with someone and kind of helping them to bare their soul and help you understand how you can help them best, it can be really quite a lot of work and quite a lot of sort of heartfelt feelings. So this is a chart. I started with like lots of feelings, and now I'm just gonna straight up bore you with a chart. And so this is the 4-box model of clinical ethics. You don't have to memorize it. What you need to understand is each principle, like the fancy Latin words that they put with it, you can put into a clinical box. And so the first one is medical indications. That's kind of an easy one, but I think it's easier for other types of doctors that are not neuroscientists, because prognosis is more clear in other types of medicine. We still don't understand a lot of the brain, so that's where we need your guys' help. We were having a dinner with HBI, and this came up, like this idea of brain injury, right? So we have all these different technologies for brain injury, but we don't actually have a good grasp of who to use them in, because we don't really know the prognosis always. And I'll show you some data that kind of shows that even more clearly. And so it's hard to say, like, who would we actually help and how would we help them, and whether or not they would have a long-term functional recovery, for example, with a device or an implant. And then, if you get through that numbers part, of what are the chances that things are gonna go well and what happens if they don't and what are the risks. Then you have to look at the patient preferences and principle of autonomy. You can tell this is very biased talk because I also think that's harder for neurosurgeons and neurologists, because I think then you get to the part where you actually can't talk to that person often, right? Like that person might be incapacitated or unconscious. And so now you have to talk to their family member who has to give you the idea for what that person would want, which is really challenging. Then you have to think about quality of life. What does that actually mean for that person? What does that mean for my uncle who is, incarcerated, et cetera? Like, was a knee replacement for someone who's not necessarily like, wanting to run, et cetera, the right thing? Was that appropriate for his goals of quality of life? And then if that wasn't hard enough, you take it all to that final box in the corner and you look at the contextual features. And this is where our work in justice comes in, and that's everything around that person, their access, the money, can they afford it? Can someone take off work for the 6 months that it's gonna take for this person to recover? Do they have access to a rehab facility? And so that's really, when you're looking at each patient, you're doing this quick calculation in your mind, and that's really guiding in my mind, the conversations that I have. Just to highlight that a little more, this is a paper that we wrote about sort of bioethical issues in different neurosurgical settings. So everywhere from, emerging technology, which I'll focus on, but also, things in the hospital, how patients, families interact, in the operating room, in research. We have done a fair amount of work in access to clinical trials, and then one of my partners, Dr. Gabriel Lazaro Muniz, does a lot of work in understanding who actually cares for people in these devices after the trial is over. And then I mentioned sort of the system at large was in the hospital. Okay, so I'm gonna go through a few cases. I'm probably gonna skip through things because I want you guys to prime you with some information, because I'm really hoping that you'll then come up with some cool ideas. So this is an example of a patient. Are any med students here? Okay, a few. Okay, great. So this is a patient. I'm not going to ask you any questions. You're like, oh God, no, you're safe here. This is HBI. And so this is a 77-year-old who fell down the stairs, had a what we call mechanical fall, didn't like faint or anything like that, just tripped over his own feet, fell down the stairs, and was found down. So that basically means, his family came, saw him at the bottom of the stairs, not communicating, etc. And so on his CT scan here, so this is the brain, and then this is what we call an axial slice, so a slice across this way. This is the left side of the brain because we read from the feet to the head, and this is the right side. These black things are called ventricles. Those are the fluid-filled spaces with cerebrospinal fluid. And then all this gray is brain. And then the white on the very outside is bone, so that's bright. But the white right here, everything's created with symmetry to make it easier for us. And so you can see there's something here that's not here, and that's blood, okay? So that's a subdural hematoma, meaning it's underneath the dura, compressing the brain. And you can see it's shifting the brain from one side to the other. Just a quick neurosurgery training course, crash course. If a subdural hematoma is larger than a centimeter, or has more than half a centimeter of what we call midline shift, meaning the ventricles are being pushed over to one side, then we consider it operative, okay? So this is an operative subdural hematoma. There's really not a lot of debate about that part. The part that there is debate about is that this guy is not really able to interact. He has a very poor exam, and we know that that patients like this, particularly at his age range, might not be able to recover, right? So they might have the surgery, and even with the surgery, and even with the interventions that might come after it, like a tracheostomy or a feeding tube, he might not actually recover to a point where he was able to live independently. He might have to live in a skilled nursing facility. Worse, he might live where he's not able to communicate, etc. And then, worst case in some people's eyes would be death. So what should predict that decision? So this is us doing one of those surgeries. This is like our most common middle of the night type surgery. What goes into that? Who are we talking to? Most people may have discussed with their family members what they would want to do if they had a long cancer diagnosis, etc. But often it's not a conversation you've just organically had with a family member about, you know, brain injury and what you would do in those cases. Although I, being the morbid, you know, neurosurgeon that I am, would recommend that you have that conversation with people in your family. So here's what the surgery looks like. This is just so, and there are some like surgery pictures in this. So if you are not like a blood brain type person, just turn your head or you can head out. So basically what we do is we make a flap from here, and we kind of, and I said it was neurosurgery 101. So you should leave here being able to do basic brain cases, basic spine cases, okay? So you're gonna be able to, you're gonna make an incision here and fold the skin all the way forward. Then you're gonna drill holes in the skull, and you're gonna be really careful because right here in the middle is a huge vein called the sagittal sinus, and if you hit that with your drill, it's not a good day for anybody. And so then you're gonna drill around and you're gonna take off the skull, right? And if right underneath, you're gonna see the dura, which is this blue stuff here. And then under the dura, you can see this sort of like black, that's all blood, okay? So your next job is to relieve the pressure. You haven't, like, you can't like really relax or slow down until you've taken the pressure off the brain. So now you're starting to do that. That's all blood clot over the brain, and you carefully evacuate that because you don't want to scratch the surface of the brain and give the patient seizures. And okay, now you see the brain here. So now you can see the brain is not normal, right? So even though the brain, now the pressure is off of it, it still kind of has this appearance of like being sunken down a little from the pressure that it's had. And it still looks a little like bluish over here where it hasn't gotten as good of oxygen after being compressed, right? So now this next role for the patient is, you know, you may or may not put the skull back on depending on how swollen things are. And you're gonna take that person up to that intensive care unit. And they may spend a week, 2 weeks, you know, months in hospitalization, recovering and preventing secondary injury to the brain. So that's where, you know, all the work that folks that are doing TBI research comes in. Anyone who wants to, you know, put electrodes here to measure what's happening there. Sometimes we do things like that. Or people think about putting in different types of electrodes in order to be able to stimulate that brain tissue to either recover or potentially to help function around it. So we asked neurosurgeons whether or not they would do this to this gentleman if the family just said, hey, like whatever you think is best, I don't know, I'm, you know, your expertise, okay? So we asked about over 100 neurosurgeons this question. We put some in a control group where they didn't get any information. We just said, you know, what would you do? And others where we showed them this calculator that shows that, and these calculators are inherently flawed, but they're based on outcome arms of other studies, where the 14-day mortality risk, meaning die within 14 days, 65.6%. Okay, so two out of 3 people are gonna die, even if you do the surgery. And then 6-month unfavorable outcome, and I have lots of people, maybe some are on the call, that would argue about this unfavorable outcome. So just take it for what it is. It's definitely not a perfect score, but 93%. Okay, so 9 out of 10 people are going to have what we call an unfavorable outcome. That's complicated, like I said, because outcome definition is what's favorable and what's not is still very much to be determined and very patient specific. But we gave half the people this information nonetheless, okay? So half people got a little cheat sheet, half the people got nothing. Average experience of the neurosurgeon in this case was 13 years. So neurosurgical residency is 7 years after 4 years of med school, or 5 if you do a research year, plus 13 additional years of experience, okay? So this person's been training for like a couple decades, okay? So these dots all represent individual neurosurgeon response, okay? So we asked them, what do you think the chance is that you take this patient to surgery and they survive 30 days? Okay, so each dot is an individual neurosurgeon. I know your face looks concerned. You should be concerned. So this is, you know, you can see this just massive spread of patients, okay? So these are the patients that did not get this extra crash statistics. I mean, the surgeons, I'm sorry. And then even the ones that did, still just massively disparate how they guessed. when it comes to 6-month, will they be able to have, what will their 6-month functional outcome or activities of daily living look like? In this portion of it, the crash folks were a little bit more pessimistic, but you can still see like just a wild spread of sort of thoughts on patient prognosis. So I put this in here to say, you know, we are so far from understanding what the prognosis is. And if you think about that first bucket, when you're thinking about who am I offering surgery, who might benefit from a technology, this is one of the big first steps in sort of understanding that. And so, you know, even as we look at the data, there's a small sort of borderline significant effect of having crash estimates on the prognostication, but surgeons are still very much relying on, you know, their conversations with the patients, their understanding of their goals, and then also their previous experience, which could be highly biased by things like, you know, if everybody we say like, no way they're not going to survive, then right, like they're not going to survive, right? So it's sort of that, you know, that fallacy. And so, and we also as neurosurgeons, we bring a lot to the table too. So we looked at neurosurgeons' opinions when it comes to, you know, what's a bad outcome, right? Like, what do you consider is a state that's worse than death? Okay, and this work was borrowed from Scott Halpern at University of Pennsylvania, who works in ICU-based patients, and we sort of translated that over to neurosurgery. And so we asked neurosurgeons, like, what's worse, if you couldn't control your bowel or bladder, or be dead, right? Like, what would you rather? And most people are like, that's better than death. But then you see like this next one, like being on a breathing machine, right? Like that's not being intubated with a tube, but having a tracheostomy, living in a facility. There it starts to kind of split. People are sort of like, oh, that sounds worse than death to me, but there's at least 40% of people that are like, that's better than death. And you can kind of read the rest. But I think my point in that is saying that we as neurosurgeons also bring our own biases to the table. And as much as we try to be open to, you know, what the patient or the family is telling us, it's hard to escape that bias. And so these are just some papers looking at that idea. There's lots of people studying this. So a fate worse than death, long-term outcome of trauma patients admitted to the surgical intensive care unit. So this is the people that don't get better and then just end up in the hospital, and they, you know, end up, you know, being hard for families, et cetera, to take care of them. I've had plenty of patients, families in those scenarios be like, just please tell me it's okay to let them go because we really can't watch them suffer anymore. But then there's also this competing data of delayed neurological recovery after decompressive craniectomy, which is a type of surgery that I showed you for severe injuries. Okay, so how do we do that in practice? And how does that end up looking, and how do we weigh quality of life? And I'm going to go through this relatively quickly because I want to get to some other clinical examples. But basically, we looked at all the hospitals in the country that participate in the Trauma Quality Improvement Project, and we looked at a variable called withdrawal of life-sustaining treatment. So for patients with severe TBI, what percentage of them ended up having a withdrawal of life-sustaining treatment? We know that pretty much all of the patients that we take off the ventilator in this type of scenario are going to ultimately die. And so we looked at which factors sort of favor withdrawal versus not. And so we found some things that you would probably consider obvious, like having had a prior stroke, having disseminated cancer, having kidney failure, meaning that person's already really sick when they come. Those favored withdrawal. But then some things that are a little less obvious, like which region of the country you lived in, which type of hospital you went to, which race you were, race, ethnicity, and how you paid. And so some of those things being a lot more concerning, that they had effects on whether or not you had withdrawal of life-sustaining treatment. And so this is just kind of summarizing that. And so I think, you know, in I guess 20-25 minutes, that's a summary of pretty much all the work that I've done over the last couple years. And so this was a response to the paper that we wrote about this in JAMA Surgery, about dying of traumatic brain injury, palliative care too soon or too late. And their recommendation was ultimately to get some more experts involved in the communication around these cases. Okay, so I'm gonna totally shift gears because like I said, I wanna show you a lot of different things about neurosurgery and how they're interesting. And so That's the example of traumatic brain injury, kind of getting you to think about how we have discussions with patients, where there are areas that really need research and understanding, and how that could guide someone like me in using technologies. Okay, so then that's my nighttime job. Now you're in my day job. So this is being a spine surgeon. So my elective practice, meaning people that come to my office and come to see me for spinal surgery and pain most of the time. Okay, so how much do you think it costs for me to do one spinal fusion surgery? Throw out a number.
700,000.
700,000, okay, another number?
500,000.
500,000, okay. It's lower, not quite that, we're not that bad. We're bad, but we're not that bad. Right around there, yeah, so the average cost of a spinal surgery is $75,000, okay? Spine surgery is a $90 billion business in the United States alone. And back pain is one of the largest, if not the largest, disablers in the US. And so when you see that there's just this huge market around something, it can be really tricky to understand when to use new technologies and not. So these are all real things that happened during the first week of my practice, where I was getting all these different emails and texts, like you become really popular, like people that become neurosurgeons were not cool as kids, you can like guarantee that. And so, you know, all of a sudden you're like popular in a way that that is bizarre to you. And so you start, you know, getting asked to use all this different technology. So how do we like relay that and help with our patients? And often, I'm sure all of you, show of hands, someone, like if you've heard something bad about spine surgery. Yeah, most people, right? Like, oh, like I had this surgery, my grandma had this surgery and now she's doing terrible and she had to have 6 surgeries, and like, it's a pretty common story. And we have a reputation problem. And in part, we've earned that reputation problem because there's a lot of perverse incentive. And, you know, oftentimes our indications can be difficult. And so this is just a couple examples of how that can play out. So this is an 80-year-old woman that came to my clinic. Again, you're going to learn to do basic spine surgery. And then you already learned how to do a craniotomy, so you've got that part covered. So this is a lumbar spine image. This is an MRI sequence, okay? So the belly is here, skin on the back is here. This is the bottom, like the tailbone. And then you have 5 lumbar vertebrae. This is 5, 4, 3, 2, and 1, okay? So at the bottom of the spinal cord, this gray thing right here ends around L1, L2, and then it turns into nerves that look sort of like little straggly strings that we call horse's tail or a cauda equina. When you look at them, they should look like this. There should be nerves kind of free the whole way. And when you look here, you can see that you can really not see nerves at all, okay? So that by definition is lumbar stenosis, tightness of the nerves, okay? The best way we know to treat that is to just remove bone and free up the nerves, or remove disc, which is this black thing, in between here, in order to free up the nerves, okay? We can do that with or without fusion. Fusion is when we put in rods and screws to try to grow bone around and stabilize the spine. This particular woman did not need spine stability. She just needed her nerves to be decompressed, kind of open and shut for a neurosurgeon, a spinal surgeon, laminectomy surgery or decompression surgery. So I walked into the office thinking like, this is pretty straightforward, you know, heard her whole story, her kids were there. I'm like, okay, I think you need a laminectomy, and you're actually like, you're gonna be fine. Like, you're really gonna do great. This is kind of like you're in my dad's category of people, like you'll be swinging the golf club, you just need to get this taken care of. And she was like, no, thanks. I'm gonna like go home, I'm not having surgery. And so I said, oh, like that kind of surprised me. And I was like, you know, why not? And she said, you know, everybody that I know in my family that comes to a hospital like this, stays overnight, that's it for them. Like their lifestyle's never the same. You know, some don't come home from the hospital, like I'm not doing that. And so going a step further and having this, you know, individualized conversation, I said, okay, well, what if we could discharge you the same day? Like you don't, you know, we can do this minimally invasive and you can go home. She was like, oh, okay, I'll do that. So I did her surgery. We did it minimally invasive. She went home the same day. Within like a week, she was walking to her church. She came back to see me exactly one time, was like, I'm good. I think we're done here. And she did great. But this is someone that might not have had surgery, if not sort of exploring the reasons. This is another person who has a much worse looking scan. This is his CT scan, so same view, sacrum's down here, L5, L4, L3, L2, L1. And you can see here that L5 is slipping over S1. It's called spondylolisthesis. It's the most common reason in the US to have surgery for back pain. It's one bone slipping in front of the other. And, for him, he was actually kind of doing fine. So he was able to, go to walk his dogs. He was like, yeah, my back hurts, but, so he had surgery somewhere else. And it turned out that actually his life was really not conducive to having had a spine surgery. So he has his spine surgery initially, but then it turns out he's in between housing. He's sometimes living in a trailer. He doesn't have good access to medical care. He can't come to follow-up appointments. And so it's sort of a setup. And he ends up, when I meet him, coming for a massive, massive infection. And so now this bone has now basically fallen off the rest of his spine. So now he's almost completely dissociated his spine, and then he has so much nerve damage that he's now no longer able to walk. So he's gone from a little bad to terrible. And then he has to have sort of a massive spine surgery. This one you don't have to know how to do. Okay, so I'll do a break on this one. But basically we went through the front of his belly, and a vascular surgeon helped me to expose that. These are retractors in his abdomen to get down to the front of his spine to resect or take out that entire bone that had fallen off, and then put a cage in there and screws and rods to hold everything back together and decompress the nerve. So this is what this looks like.
Okay, ready? Yeah.
So there's the cage now in the front, the screws and rods in the back. So this is what it looks like when we reconstruct someone's spine. This surgery took us like 11 hours on a holiday. Not that, any of us are bitter. No, just kidding. So, what's the difference between these two patients and what kind of things that they bring to the table? And I think this is where, I find my job to be fun, because I get to interact with just so many different people from so many different walks of life. So our first patient is Black, right? And so you might think, she was going to be the one that had the bad outcome. She ultimately had a great outcome, right? And she came from, a middle-class family. She had a good education, and she made decisions in a different way than our second patient, who's a white male from a rural location, had a high school education, worked a physical labor job, which is really important when it comes to surgery and, where and when you need to go back to that job. And didn't have the family support, et cetera, to help with, somebody who could have surgery the same day, go home, and everything kind of would be taken care of for them. So I would argue that these patients have a lot in common. Number one thing is that neither of them want any more spine surgery. But I think the reality is that there's a lot in common between patients. And when you start thinking more on those sort of models of, okay, what can I do? Is it helpful? Is it not helpful? What's the chance of being successful? Does this person actually need this for their quality of life? I think we can do a much better job in spine surgery of finding a good fit. So I'm gonna so there's lots of reasons to have surgery and lots of reasons not. And this is the type of research that I do. So we look then into patient-reported outcomes and try to understand, like, okay, why do certain patients have surgery and certain patients don't? What are their symptoms look like? We actually did find in this study that in this particular study, we focused on race ethnicity as a difference, but there's so many different ones. We also have looked at insurance status, where people live, area deprivation index, those types of things to understand. And so the take home from this one is basically patients get an iPad and they fill it out when they come to your office, and they tell you how their physical function is and how much does pain interfere with their lives. And so interestingly, this is in the Mass General Brigham system. Our patients that were non-white actually said that their pain interference, reported worse pain interference, and reported worse physical dysfunction, but were less likely to have surgery and had worse outcomes. So again, there's sort of this mismatch of why is that happening, and that's where we study and interview and try to understand. And so there is this idea that uncertainty, when prognosis is uncertain, when treatment is uncertain, when you don't know, that can actually widen the gap between people people. And so that's where I find it to be really fun to figure out better ways to communicate. This just says the same thing. And this is just one example of that type of a study where we looked at disparities in decision making. And so in comparing patients of different race, ethnicity, we actually found sort of different ideas and themes of why they have surgery. So every patient talked about emotional suffering with pain. That's a huge component of pain. Every patient talked about support and having support systems, but our BIPOC patients talked a lot more about needing to get back to work, not being able to get away from work and those needs. And then our white patients tended to talk a little bit more about wanting to get to quality of life things, like wanting to be able to play tennis, those types of things that were just different concerns and need to be met in different ways. So these, I'm happy to share these slides with you, but it just talks a little bit about these different themes of emotional suffering and then financial and occupational concerns. So we work with students and in our research on bidirectional communication. So, that first step is figuring out what the patient's actually bringing to the table, asking and listening, offering facts when you have them, like being generous with what you know. I think we as physicians have been trained to be so patient-centered, which, I love, but at the same time, you are an expert, so it's okay to say the things or at least, say them in a way that has some humility communicated, but is not just well, I don't know what's gonna happen, why don't you decide what you want, is not exactly what patients want to hear. And then give numbers, but don't hide behind them. So I think it's 20% of Americans can calculate a tip on a bill without a calculator. So when you tell someone it's a 17% chance of XYZ, you just need to understand how many people actually that means something for them. So I tend to use, instead of that, I would say 2 in 10, or, if 10 people had this surgery, 2 of them would get an infection. It just hits home a lot better for folks. And then understand that the expectations that they have and the communication that they have is actually going to determine whether or not your treatment is successful. So I work with the Health Decision Science Center and the Shared Decision Making Center on this type of idea. And there's a lot of reasons why to do it. You can see them here at the bottom, but I think, thinking about this as a way to do informed consent and really bridge health disparities is why I find it helpful. Okay, I'm just gonna throw some technology at you now because then we can have a discussion of it, because I know I'm gonna end in just a couple minutes for questions. So there's a lot of different ways we can fix the spine. This is the example of the spine robot, which we use both at MGH and at Brown. So we can use it for different types of docking and placement of screws. These types of procedures can be done really well through tubes. And so sometimes, like the surgery that you saw the gentleman had, sometimes we can do it with sparing the muscles by doing things through the tube. So this is us operating through a tube to make things less invasive, spare muscle on our way in. Skip a lot of this. I want to show you guys a video. And so then, thinking about when I went to that beginning slide of okay, what tech do we actually try and what tech don't we try? Because you want to be trustworthy to those patients that are coming to you for these things. So you could use a robot, you could use an endoscope, you could use a tube, like some of the things I just showed you. The question is when do you do that and when don't you? So I trained on robotics and tubular surgery as a resident and a fellow. So that was just part of my everyday, this is how I do it. What I didn't train with was an endoscope, right? So an endoscope is a small camera where you put the instruments through, you can make a really small incision and you can actually get a wide view of the spine and treatment possibilities. And so this was something that I decided to take on, and I think it's really important that we as surgeons think about our relationships with companies in these types of ways. There's some really good guidelines out there to think about how you go through this process. I think really important that this is what our OR looks like, right? So you can see it's just there's technology everywhere, there's industry everywhere, we can't do it all ourselves. I'm forthcoming with my patients about the fact that I'm doing that. Like when I did the first endoscopic spine surgery at MGH, I said like, hey, this is number one, like, isn't that cool? But also like, FYI, this is number one. And so, you know, and I said also, hey, there's people in New York City that may have done more than me. Like if you want to go there, like by all means, you know, like making sure that they understand that. So not rushing that separation, but discussing the benefits and also discussing some of the risks, and making sure that industry is part of our team. So we have reps in our room every case. They make sure the endoscope's clean, that the right instruments are there when we need them, but they don't replace our judgment. So it's not like I'm looking at the rep and being like, is this what I do next? And so I think that's really important. Here in Boston, there's been a lot of issues with that, just making sure that we, as you know, as folks in a hospital are not making decisions about companies that we have relationships with. And it is sometimes important to have a relationship with a company to try to make the technology better that you're using. And so I'll just show an example of what it looks like when we do this type of surgery. So this patient had a lot of arthritis between their lumbar levels 4 and 5 that was compressing the nerve. And so we use the endoscopic. And here's where we dock in on the spine, so that this is the DRG, or dorsal ganglion of the nerve. And often what will happen is disc or bone will grow over and start to compress it. And so this is just a video of that. So once we get in there, we're looking through often like a 6 millimeter or 8 millimeter tube, and we're actually able to take disc out. So that little fragment that you saw kind of flying at you, this white stuff is disc. And we can remove it through these sort of tiny cameras. So here's another example of that. They also have like a monopolar cautery, so you don't injure the nerve. So you can use bipolar cautery through a monopolar probe, because you can't put something that you can squeeze through this like long camera shaft. And so that is really a really cool technology that's being used in these particular procedures. And then this is just sort of another example of that. And then I'm gonna end there. So there you start to see, this is called epidural fat, this yellow stuff, and the nerve underneath of there that's now going to be decompressed. So right under here where you see this stuff pulsing is where the nerve is. So you start to free up the nerve that way. So we can do all kinds of stuff like that. We can deliver medication. We can cut, not these types of nerves, but other smaller nerves that are causing pain potentially. And so this is kind of what we do. I'm not going to go through too many more slides, but just to say that, you know, it's a team effort that's involved in that. And I think that is really, you know, a part of what makes it fun, being able to develop that. And a huge part of the team is also the patient. And then I'll just put a very quick plug in for our team at Neurotech Justice Accelerator. So we do a lot of the work that I just described, as well as neurolegal work and more neuroclinical research at the Neurotech Justice Accelerator. If you email us at ngm@mgh.harvard.edu or go to neurotechjustice.org, we'd love to work with you guys. And I told my daughter I talked about boats, so this is our recent trip to Cape Town, South Africa, where we went on a boat. That's all I have to say about boats. All right, thank you guys. Happy to take any questions.
I was really struck by the the huge range of outcome or decision to do the surgery on in the first case study that you presented. Prognosis variability aside, which it sounds like a lot of people understand that there's uncertainty about. What variables do doctors tend to lean on the most to make decisions like that?
Yeah. So I think, you know, probably first and foremost is like age, honestly. And it's interesting because some of my neurology colleagues that would like us to do more neurosurgery on these types of patients would like to expand the ages that we're thinking about doing this surgery in. for surgeons, we often are like, if the sentence starts with like, there's a 90-year-old who you're like, you start to like drift to the back. But that's not really correct anymore. And so there is potentially some bias there in terms of, there's facts, right? Like one of my colleagues will say like, no matter how good they look on the outside, they're still 90 on the inside, which is very true, right? Like there are medical facts about aging. But there's also the case that like there are some people that are independent. And so that's something that we rely on, that I would say people rely on in a variable way. So age is a big one. Other, issues or diseases. So does the patient already have liver failure or already have stage 4 cancer or something like that, where it's like, oh goodness, like we would have to get this person not only through the surgery, but then also to chemotherapy, which in order to do chemo, you often need to be able to walk into a chemo center. So now we're like, this is not going to be able to work out. And then we look at the actual imaging. So how severe the imaging is, how bad of an injury, is there scattered blood everywhere? We are seeing that data is actually, we probably shouldn't rely on that data. It's not a great prognostic marker. And then we have advanced technologies, which some of our NGM fellows are doing research in, like fMRI, FNIRS, things like that, that we can actually do to help look and understand whether or not people have, because there's this thing where people are minimally conscious, where you think that they are comatose, but they actually will respond. Like if you put them in an fMRI machine and tell them like raise their hand, they won't move their hand, but you'll see their brain, light up to show that they're actually processing that information. So that can be a prognostic sign. So those are the types of things that we tend to rely on. I think probably where you see the most variability is that even though all these technologies exist, they don't exist in everybody's practice, and they didn't exist in everybody's training. And so I frankly learned a lot about a lot of these technologies as, faculty, which is kind of why.
Thank you so much for all the work that you do. It's really incredible. I know you mentioned for instance, the factors for craniotomy, so like to do subdural hematomas or epidural hematomas or something like that. But I feel like when it comes to spine, so then you have like specific markers of like maybe the prognosis is like 93%, or they might have like some secondary things. But I feel like with spine, most of the time it's really like a 50-50 chance, and there is not that much research on and people, even neurosurgeons, have like very wild discrepancies on
Yes.
what they will do. So how does that usually play a fact when you're dealing with spine surgery?
Yeah, I think that's actually why I enjoy spine surgery, because there is a lot to think about in that realm. I think I always tell patients, because the problem is like, we have these big data sets that will say things like, okay, 15% of people, with an infection, or, we'll get an infection or this or that. But each surgery that we design is so different and so patient tailored that sometimes it's really hard to like apply like a large data set number to the person in front of you. So that's one thing that I think makes it hard. The other thing is like everybody's indications are very different. And so they are trying, they being payers, they being neurosurgical and spine societies, to sort of put out guidelines around like, hey, this is what can be done, right? So if we follow, and they showed, Jim Harrop did a really nice paper he's done at Jefferson, I think it's in the Red Journal of Neurosurgery, where he actually showed that patients have much better outcomes if you adhere to a lumbar spine treatment guideline, right? So if you're not just like willy-nilly, like, yeah, this seems right today, and unfortunately incentives do work, right? So we have this conversation amongst our colleagues of like, the reality is if you pay someone to do like a particular type of surgery, and they make 10 times as much to do one surgery than they do the other surgery. If it's on the fence, which surgery do you think they're gonna do, right? Like, you have to be realistic about like, and that's all of us included, like that's not a conscious decision, but like incentives work, otherwise they wouldn't put them there. And so I think, people are starting to work on things like aligning incentives and thinking through that, which I think is really useful.
I'm interested in pursuing neuropsychiatry in the future. I wonder, do you see Neurotech crossing over into treating psychiatric conditions?
Yeah, absolutely. So I think, so yes, in many ways it already has. So things like treatment of OCD, different like severe depression, people are looking at even addiction, and substance use dependence. People are looking at deep brain stimulation to treat these types of disorders. It's ripe with ethical issues because neurotech and neurosurgery, like for people like my uncle, for example, was used in a really inappropriate way to try to sort of like get rid of behavioral deviance in society, those types of things. And so we have to be really careful about patients consenting to that, understanding what the long-term treatment is. So if they really like the way they feel when they're on this device, but it's only a trial and it's been 2 years and now the trial's over, like what do we do to that person, right? We take the device away, or is that, who continues to pay for and support that type of device? So I think there's a lot of ethical issues, but yes, it is already crossing into neuropsych, and there will be a wide range of prognostic possibilities.
Thank you so much for your work and your talk. I was wondering, so you mentioned spine surgery, there's like some people go in 5 or 6 times. Is that just the nature of the field, or do you think that comes down to sort of the decision to operate or not?
I think it's both. I think, there's certainly patients where I felt like, I came up with a really good plan and we did, what I thought was like really gonna work, and then they needed something more, right? It wasn't enough, they still had pain, etc. We don't always there are some now advanced imaging techniques like SPECT and PET to try to understand like pain, but when you're treating pain, because it by definition is subjective, it's sometimes hard to treat like definitively. I had some other examples of spinal cord stimulation, which is another type of procedure that I do, that I think can also be really important in kind of understanding what the possibilities are for neuromodulation versus purely sort of structural fixes. And so, yeah, I think it's just, there's a variety of options, there's a variety of indications, and then the outcome marker, we as spine surgeons, it's on us to kind of get better at figuring out what we're measuring.
I had a question about the story you were telling about the
Yeah.
lady who was not sure about the surgery,
Yeah.
but when you said that, you can do it so she doesn't have to stay in the hospital
Yeah.
overnight.
Yeah.
So I was curious, like, if that were possible, like, what was making you first think of the other option? Like, were there some benefits to not doing the minimally invasive?
Yeah, so I actually in my head was always, for this particular patient, was always thinking about the minimally invasive, but I just never even got that far, like I was sort of like, do you want surgery? And to her, surgery meant like surgery, like we're gonna like open up everything and you're gonna be here for 3 days, and like, and so it was just that, like hearing that reflected back to me, like almost luckily, because I just so happened to be like, oh, that's kind of weird, like why, and so yeah, so hearing that reflected back, I realized like, oh, I never like to tell people like, oh, it's so minimally invasive that they feel like they're like nothing, like, oh, I'm basically gonna walk in and out and you're gonna like shoot a laser, and then like, cause I'm like, no, it is surgery, like, you still have risks, etc. You still have anesthesia and all these other things. But I think, so it kind of tailored the way that I might talk to someone about that, like not overly, pitching minimally invasive, but also making sure that they're clear that that is a very different option.
I also wanted to thank you for your heartwarming presentation and all the work that you do. I was wondering, so since your work in decision making, as a physician, what do you do when a patient doesn't have decision making capacity, as well as a surrogate, as well as advanced directive? What happens then?
Yeah, it's a really great question. So if you're interested in questions like that, I did a surgical ethics fellowship at the University of Chicago, and then also there's the Center for Bioethics here that has a lot of rich discussion and around this. And this is a very common reason for clinical ethics consultation, right? So it could be someone who, is unhoused, and then, we can't get in touch with family. And the answer is complicated because it depends on your state. So here in Massachusetts, one of the things I learned, not having practiced in Massachusetts, is they actually will accept like, this is the closest person to this person we kind of can find, right? And so, so if this person had like a best friend who, is not actually blood related, and who doesn't have like the paperwork for power of attorney, but has sort of evidence that they had a close relationship with this person, they actually will accept that person as like a surrogate decision maker. So that's one option. If you can't find anyone, and you know, our social workers tend to be pretty amazing at tracking folks down, but let's say you can't find anyone, then often those decisions are made by the court. That goes to the court, which can be tricky because it can be kind of a long process. So these emergent decisions, like whether or not the patient goes to surgery, and if there's nobody, so for a total of like a life or death emergency, we can take someone to surgery without consent. When it comes to things that are now like semi-elective or like, you know, there should be time for thought, usually it's two physicians to make the decision together. You can't make that decision usually as a physician by yourself.
Question on
Yeah.
Zoom. I've heard it hypothesized that catastrophizing about post-surgical pain after spinal surgery is associated with worse outcomes, and that cognitive or behavioral interventions may be helpful. What is your view of this?
100% agree. We have pretty solid data at this point that patients' sort of perception of pain, as well as any underlying mental health diagnosis like anxiety, worsen outcome after spinal surgery. So we have actually at Newton Wellesley at the Wells Ave Spine Center and at MGH, but at Newton Wellesley they actually have like a pain clinical psychologist, and she runs like a group, like a support group for patients going through pain post-op, because often, and there's some great literature about this also in the joints, like ortho, hip joints, that if you treat patients that way, sometimes they don't even need to have surgery because sometimes they're just so nervous and afraid of the pain that it actually, you know, there's a loop that sort of reinforces this feeling of pain, which can be very visceral, and sometimes getting out of that loop. There's a book called Your Body Tells a Score. Body Tells a Score, yeah, that talks about this concept. I think the person that wrote that works here, right? I think so, yeah. You should get that next. I'll come to that talk.
Might be a very lame question, but I mean, considering say a glioblastoma, which is like a very high-grade tumor as such, where we might have to resect off, you know, some amount of brain tissue as such, right? Comparing that to a traumatic brain injury, how does the prognosis relate to the preoperative planning time that the surgeon might get?
Great question. And I think it kind of like elucidates the difference. So his question is related to glioblastoma, which is a high-grade brain tumor, and then versus like a TBI and how we understand prognostication between the two and how that affects treatment. And so in GBM, there's this famous trial called the STOOP trial. And what that trial tells us is that if we get a gross total resection, which for those of you who know GBM, you know that you can't really take out the whole tumor, even though you take out the mass, there's still going to be tumor cells spread throughout the brain. So, but if we get as close as possible to a maximal resection, now there's more data showing that if you even do like a supramaximal resection around, and then the patient doesn't have a substantial neurodeficit, right? So that's what's really tricky. I don't take out brain tumors for a living, but I did during residency. And so the really tricky thing is that patient has to kind of get out of the hospital really quickly, have a good functional status really quickly, because then if they get into radiation and chemo like right away, as soon as their wound heals, they have the best chance of survival. Even with that good chance of survival, I believe the study says around 13 months. Median. Obviously, there's people that have lived for way longer. There's people that unfortunately have lived for shorter. And so I think in many ways, in my interactions, because in residency, we take care of everybody, right? All different types of pathologies. In my interactions with those patients, it's tremendously sad, obviously. But there is an opportunity to really help and understand like what the prognosis is, and it is pretty clear. I think what plays a different role in prognosticating in those types of cases is the role of hope, right? So this role of like, okay, well, what if there's this other clinical trial? What if I'm this person that's like, you know, gonna be the one that has survived for 10 or 15 years where I trained at Duke, we had, you know, poliovirus and different interventions. So I think, you know, prognosticating around that can be tricky, but I think there is a little bit more clear data about prognosis that I think can help guide treatment, so that there's very few patients in those scenarios that would say like, okay, I have my GBM, like, don't take it out, like, because, you know, it's only gonna be 13 months. Most people are like, I want to maximize that time, I wanna maximize my treatment options. So I found those conversations to be a little bit easier than the ones around brain trauma, because also they're really fast decisions in brain trauma. So it's, you know, it's 3 o'clock in the morning, you know, you can sort of imagine the scene, like you're in the ER trauma bay. It's not like a nice office where you are having like a face-to-face conversation with someone, or even sitting down in a hospital room. You're like sitting in the ER waiting room somewhere, trying to like get a quiet moment to have this like really massive conversation. And then you don't even really have all the information that you need.
We don't have more questions. Thank you so much.
Thank you, guys. Still in the waiting room.
So people who are joining for the lunch can come to the front, and if you